So we will discuss the ultrasound of the knee, posterior aspect and lateral aspect. We shall follow the steps. So first is choosing the correct probe. Secondly, apply the preset. So preset may be there in your machine set by the manufacturer, or you can make your own preset also. For different parts of the body you can make different preset. Then position the patient. Position should be correct so that that part is easily visible by the ultrasound. Then mind the aspect marker. From before starting the ultrasound only, you should see the aspect marker of the probe, which matches with the left side of the screen usually. So you should mind that aspect marker which side you are seeing, and then apply gel and decide axis and start scanning. So before starting only, we expect the structure to see in the ultrasound, then only we can do a good ultrasound. Then palpate the anatomical landmarks. So before putting the probe also, we will see that which area we are palpating, which area is visible from outside. So anatomical landmarks also gives us a nice guidance to do the ultrasound. Then during ultrasound we have to adjust the gain, depth, focus, frequency, etc. So this is the position of the patient, or in our case it is the volunteer, to examine the specific parts. So today we are seeing the posterior side of the knee. So patient should be lying prone to see the posterior part of the knee. For seeing the lateral side, this type of position is better. So we can palpate few anatomical landmarks before starting the ultrasound. So here you can see that we can palpate the upper pole of the patella, lower pole of the patella, and then the joint line. Joint line we can palpate from medial side also and lateral side also. Okay, then you can see here, this is the Gardis tubercle. So on the tibia, on the lateral side, it is the Gardis tubercle we can palpate. In the midline, you will be able to palpate the tibial tuberosity. So this tibial tuberosity and Gardis tubercle both are important landmarks. And fibular head, we can palpate the fibular head also. So this is also another important landmark. So what we have palpated: upper end of patella, lower end of patella, tibial tuberosity, Gardis tubercle, and then fibular head, and then joint lines also. As far as probe selection is concerned, for examining the lateral side of the knee, a linear probe is often sufficient. But for examining the posterior side of the knee, a linear probe is all right for a thin individual. But the patient, if the patient is bulky, then of course you have to go for the curvilinear probe. And for seeing the small cutaneous nerves, we will prefer a very high frequency probe, maybe a hockey stick probe. We will see the structures in this way, from deep to superficial. So deepest structure is bone, and then joints, then ligaments and retinaculum, muscle, different type of muscles, all are from the posterior aspect we will discuss today, and then bursa, and then nerves, small nerves are there. So we will see all those. So as we know that knee joint is formed by femur, tibia and patella. This fibula doesn't come under the knee joint. The knee joint is divided in three compartments. One is your medial tibiofemoral compartment, one is lateral tibiofemoral compartment, one is, if in the front side, patellofemoral compartment. So here from the posterior side we will see both the condyles, medial condyle and lateral condyle, and intercondylar groove of femur, and then we will see the tibia and fibula from the posterior side also. Meniscus, on the other hand, can be clearly seen from the lateral side or medial side. It is, of course, can be seen from the front side also, where the patella is not there, just paramedian to the patella. If we put our probe in a long axis view, then we can see part of the meniscus. But from the posterior side, meniscus cannot be seen as it is a very deep structure. So as far as ligament is concerned, the most important ligament in the lateral side is lateral collateral ligament, or its name is fibular collateral ligament. It stretches from the lateral epicondyle of femur to the head of fibula. It is actually separate from both the joint capsule and the lateral meniscus. It protects lateral side from an inside bending force. I mean like varus force, where it protects from varus force. It protects the knee. There is another ligament which here you can see, this is called anterolateral ligament. This is also situated in few cases, not everywhere. This is there in front of LCL, in front of lateral collateral ligament. So under ultrasound, lateral collateral ligament looks like this. This is the lateral collateral ligament, okay? And knee is extended. You can put the ultrasound probe in a longitudinal axis, and you can see the lateral collateral ligament in this way. Okay, it is getting inserted on the fibular head, and here under the lateral collateral ligament, here you can see. Of course, it is not that clear. I will show that here should be the popliteus tendon. You can see the popliteus tendon here. So this is meniscus. These are fibrocartilage, semicircular structure. Two fibrocartilages are there inside the knee, and both of them have anterior hand and posterior horn of medial meniscus and lateral meniscus. But here, of course, with ultrasound, we can see a part of the meniscus and not the whole meniscus. So to diagnose a meniscal tear and all, MRI is better than ultrasound. So now let us go to the ligaments. To understand all the ligamentous structure of the posterior from the posterior side, we divide these areas into three parts or three compartments. So one is central knee. We will put our probe in the central 1/3 of the knee, and then posterior middle portion, posterior medial corner of the knee, and then posterior lateral corner of the knee. So if we divide in equal 1/3 divisions, then first we will see the central 1/3, then medial 1/3, then lateral 1/3. So if you see the central knee, we can see this is an MRI picture, of course, and we can see that this is the ACL and this is the PCL. In the central part, we can see this type of ligaments. So when we will see by ultrasound, then also from posterior side, we will try to see the posterior cruciate ligament, PCL, and another structure is there that is called meniscofemoral ligament. So see these two pictures. So here in this picture, so here this is the fibula. So we can understand that in this picture this is the lateral side and this is the medial side, whereas in this picture this is the lateral side and this is the medial side. This is showing the posterior side of the knee, and this is showing the anterior side of the knee because patella is there. Now, as we are focusing in the middle part, most middle 1/3, so we know that ACL and PCL, two ligaments are there. Now, you try to remember that when we were seeing ACL, our probe was upper end of the probe was directed outwards, okay, because it was getting inserted to the medial side of the lateral condyle. But when PCL we are seeing, it is directed towards the medial side because the posterior cruciate ligament stretches from medial condyle of the femur to the posterior intercondylar area. So actually here this PCL, posterior cruciate ligament, these also have two bands of fibers, okay. So one is anterolateral and one is posteromedial band, but both are PCL. So this PCL is actually anterior side of the PCL also have one fiber, that is anterior band of meniscofemoral fiber, and posteriorly also there is posterior band of meniscofemoral fiber. You can see this small band. So this is anteriorly, so this is the anterior band of meniscofemoral ligament, and this is the posterior band of meniscofemoral ligament. So remember, meniscofemoral ligament is very much related to the PCL, but ACL is most anterior. So if we think the structures in the middle part from anterior to posterior. So you can see ACL is the most anterior, then comes anterior band of meniscofemoral ligament, then comes PCL, and then comes posterior band of meniscofemoral ligament. So under ultrasound, PCL looks like this. Of course, we will see under ultrasound. This is PCL. Now let us discuss the posteromedial corner of the knee. It has 5 major components. One is semimembranosus tendon and its expansion. Next, posterior oblique ligament and oblique popliteal ligament. So these are two different structures, posterior oblique ligament and oblique popliteal ligament. Then deeper to that, that is posteromedial joint capsule, and then posterior horn of the medial meniscus. So we have already seen the both the meniscus has anterior horn, posterior horn. So in posteromedial corner, of course, we will see the posterior horn of the medial meniscus. Here in posteromedial corner, we will not include the medial collateral ligament, that is part of medial knee, and posterior side it is not there. So let us see this picture. So as I told, semimembranosus tendon and its expansion. So this is the semimembranosus tendon, and it expansion means it has multiple divisions. Okay, so I'm not going in detail of it. So this is there in the posteromedial corner, and below that, if I remove this one, then there is a oblique, posterior oblique ligament. So this is the posterior oblique ligament, and here it also has the multiple sleeves. Okay, so capsular arm, central arm, distal superficial arm, so it also has multiple divisions, but this is one important ligament. Of course, we will not be able to see under ultrasound all the ligaments separately, but we should know that there are too many ligament complex in these areas, and they are the, if injury to this ligament complex gives a continuous nagging pain, continuous chronic pain to the patient. So next ligament is oblique popliteal ligament. So this ligament is a large ligamentous structure of the posterior knee. Actually, it starts from the posterior surface of the posteromedial tibial plateau. Okay, so from tibia, from here it starts, and ultimately it goes laterally, and it attaches to the either fibula or the lateral gastrocnemius tendon. So this is also a very deep structure, oblique popliteal ligament, and it also has multiple variations of its shape. Either it is band shaped, Y shaped, Z shaped, trident shaped. So different type of shape has been found. So in the posteromedial corner of the knee, there are, you have already understood, there are two ligaments. Okay, posterior oblique ligament and another is oblique popliteal. Similarly, posterolateral corner of the knee is also a very complex area and can cause chronic pain if that is injured. So here also 5 structures are there. Here lateral collateral ligament is a part of that 5 structure, whereas in the posteromedial corner medial collateral ligament was not included. Then comes few small ligaments. One is arcuate ligament, then popliteofibular ligament, fabulofibular ligament if the fibula is present, and then posterior third of the lateral capsule. So that is the tippermost structures, and these are sometimes included, sometimes not included. That is gastrocnemius muscle, lateral, and biceps femoris tendon, popliteus musculocuneus complex. So these things are sometimes included in some literature and sometimes it is not included. But remember, in the posterior side, so arcuate ligament and popliteofibular ligament, so these are important ligaments. So let us see the schematic diagram of these ligaments. Here you can see the biceps femoris tendon on the lateral side, and just below the biceps femoris tendon there is a white structure. So this structure is nothing but the lateral collateral ligament. Okay, this lateral collateral ligament is actually it is sandwiched by the short head and long head of short head and long head of biceps femoris. Okay, so there are other ligaments also in the posterior side, because this is the patella we can see. So this is anterior side and this is posterior side. So other ligaments which are there in the posterior side, this is fibulofibular ligament, and then arcuate ligament is also there. There is popliteofibular ligament is also there in the posterior part. So if we see from above, so you can see that here lateral collateral ligament is this red one. This red structure is lateral collateral ligament. Anterior to that, this is the short head of biceps. SB means short head of biceps. Of course, there is also anterior and deep fibers, but we are okay. I mean, like short head of biceps is positioned in the anterior to the lateral collateral ligament, and then just posterior to that, that is the long head of biceps femoris. Okay, short head of biceps femoris, long head of biceps femoris is inserted, and in between that, that is the lateral collateral ligament. So that is the orientation. Okay, and then if you come more posteriorly, then at this area you can see fibulofibular ligament and arcuate ligament. Okay, so this is the arcuate ligament. It also has the medial fiber or lateral fiber. So this is the arcuate ligament, and then most posteriorly it is the popliteofibular ligament. Okay, so this is the orientation. We can see that how the ligaments are attached. Of course, we are not able to see these small ligaments separately with ultrasound. Even these ligaments are not present in all the knees. Even the arcuate ligament, this arcuate ligament is present only in 65% of cases. Even the fibula is also not present in all the. We can see the popliteofibular ligament with a high frequency probe. So see the location. This is the popliteofibular ligament location. So when we place the probe longitudinally, so we can see, so here it is the cranial side, it is the caudal side. We can see this popliteal tendon in a short axis view. So this is the popliteal tendon. Okay, and this is the fibula. So fibular head is this side head of the fibula is there. In between, of course, we will see some part of tibia also. So this is the cortex of tibia. So between this fibula and proximally this popliteal tendon, in this area we will see the popliteofibular ligament. Above that, of course, we can see the inferior lateral genicular nerves, genicular vessels. Above that we can see. So we have already talked about the fibulofibular ligament. So this is the fibula. This we know that this sesamoid bone we find in the lateral head of lateral gastrocnemius tendon. Within that we find this fibula. So fibulofibular ligament is there in nearly 48% of individuals. It is there. And here it is below the gastrocnemius tendon. This small ligament is found. Of course, it can be seen by MRI in a much better way. So this is fibula. We can see under X-ray also, and in MRI also we can see small fibula, and with ultrasound it looks like this. Okay, so this is an accessory bone that is most of the time found in the lateral head of the gastrocnemius. Sometimes it can be found rarely in the medial head of the gastrocnemius also. Now comes patellar retinaculum. So it is there in medial side also and lateral side also. It also has two layers. One is superficial and one is deeper layer. So you can see this is the lateral patellar retinaculum. So this is bounded by the iliotibial band. This is the superficial layer. This area. Oh. So this is the bounded by the iliotibial band, and this is the superficial layer of patellar retinaculum. Okay, and if we remove this superficial band, then there is a deep band. Deep band also has slips which comes up to the tibia, up to the tibia or up to the lower end of femur, and so ultimately this comes to the iliotibial band also. So this has different slips. So these are we can remember that patellar retinaculum is present in the lateral side and medial side both, and it has superficial and deep layers. Okay. Likewise, this is the medial patellar retinaculum. It also has the superficial and deep part. Superficial is the your limited. It is limited by the vastus medialis tendon, vastus medialis tendon, and here in the deep part, of course, this has multiple sleeves. So under ultrasound, patellar retinaculum looks like this. So this is the lateral femoral condyle, and this is the patella, and this part is the patellar retinaculum. Now we will see all the muscles. So from posterior side, it is the only few muscles are there only. So if it is the lateral side, so in lateral side from above we can see it is only the biceps femoris. Of course, it has two heads, short head and long head, and then in the medial side it is only semi-tendinosus and semi-membranosus. Now from below the superficial muscle is the gastrocnemius. Gastrocnemius, it also has the medial gastrocnemius and lateral head of gastrocnemius. Then if we remove these superficial muscles, then another two muscles we see in the knee region. One is plantaris. This also starts above the lateral epicondyle area, and gradually it becomes a tendon only. And then another muscle is popliteus. So you can see this is below the here you remember that in the lateral side I showed you while showing the lateral collateral ligament, there is a tendinous insertion in the groove in the lateral side of the femoral condyle. So from there the popliteus starts and popliteus comes in this way. So plantaris starts from above the lateral condyle and popliteus comes below the lateral condyle. So another important structure is iliotibial band, and iliotibial band syndrome is a known morbidity. Known disease. So okay, iliotibial band, it is formed by the fibers of the gluteus maximus and tensor fascia lata. Of course, some fibers from gluteus medius also forms the iliotibial band. We will see this structure. So we can see the iliotibial band which inserts at the Gardis tubercle. This one is the iliotibial band. If we put our ultrasound probe in a longitudinal axis in this way, then we will be seeing the lateral femoral condyle, and above that this is the iliotibial band. In a short axis view also we can see the iliotibial band over the lateral femoral condyle, and as it is inserting in the Gardis tubercle, so it is the anterior structure. This side is anterior and this side is posterior. So this iliotibial band we can see, and posterior to that we will be seeing the lateral collateral ligament. So this is a short axis view. So anatomical relation of iliotibial band, lateral collateral ligament and biceps femoris tendon, they have a relation. So this side you can see, this side is the proximal side, this is the femur, and this side is the distal side. Okay, so this is the iliotibial band. So iliotibial band is the most anterior structure. Then if we fishtail our ultrasound probe, we keep the proximal side fixed, and just distal side we rotate from tibia to fibula, from Gardis tubercle to fibular head. Then we will be seeing the lateral collateral ligament, and then if again we fishtail our probe, we fix this part now where the lateral collateral ligament is inserted, and the proximal side we fishtail in this way, then we will see the biceps femoris tendon. So it is sometimes called as a jet technique. You can say that this is the jet technique. So for this jet technique is used to see all three structures: iliotibial band, lateral collateral ligament, and biceps femoris tendon. Now comes the bursa. So here posteriorly we will be seeing only one bursa. So this is called semi-membranosus gastrocnemius bursa. You can see this one actually. So this is between the medial head of gastrocnemius and semi-membranosus tendon. So this is actually a you can say this is a recess, because this has a continuation with the joint. But of course fluid, if effusion is there inside the capsule, fluid can go into this side, and many times fluid cannot come back. So if there is a effusion in this bursa, then we call them as Becker cyst, and then you have to aspirate the Becker cyst for treating the patient's symptom. So this is a picture demonstrating the capsule around the knee joint, and you can see that in front side also there is the recess, which we can see as suprapatellar bursa, or it is the suprapatellar recess, and posteriorly also we will be able to see the semimembranosus gastrocnemius bursa, but both are actually recesses. Now we shall discuss the nerves around the knee. So nerves, ultimately there are what it supplies. It supplies the joint capsule and the muscles around, and of course the skin above the I mean the cutaneous innervation. So three types of innervations are there. So here you can see the very small nerves. They are supplying. They are dividing into very small nerves, and they are supplying the capsule. Actually, all the small nerves which are supplying the capsule, they are ultimately the branches of sciatic nerve, and then tibial common peroneal nerve, femoral nerve, saphenous nerve, and even the obturator nerve has small branches. Now, as a pain physician, when we are dealing with a patient of knee osteoarthritis, say grade 4 knee osteoarthritis, who doesn't want to get operated, then for symptomatic relief actually, then we will target the nerves which are supplying the capsule. So you can see these are the branches. We can, if we think separately, different genicular nerves, then superomedial, infromedial, superolateral, infralateral, we can separate by quadrants, and we will get different genicular nerves. And posteriorly also there are multiple genicular nerves. Today, as we are talking about the lateral side of the knee and posterior side of the knee, so among these genicular nerves, we will see the superolateral and infralateral genicular nerves. Actually, nerves are not clearly seen. We always target the genicular vessels which are associated with the genicular nerves. Sometimes we see the nerves, otherwise genicular vessels are very clearly seen. There are multiple literatures. Some says that always there is not the nerves are not in close vicinity of the genicular with the genicular vessels, but mainly we target the genicular, we see the genicular vessels, and just by the side of the genicular vessels we search for the genicular nerves, and we target those genicular nerves. So we can see this is actually vascular structures, we can see. So vascular structures also are associated with the genicular nerves. So each genicular nerve has a small vessel associated with the its course. As far as cutaneous nerve supply is concerned, means it supplies the skin around the knee. Then there are many small cutaneous nerves. So either these can cause pain by entrapment neuropathies. Different entrapment neuropathies can occur on which affect these nerves, or this can cause neuromas also after, say, surgery, when the inadvertently or during the surgery these small cutaneous nerves are cut. They can form a neuroma, and it can cause a post-operative neuropathic pain. So this slide is about questions for you. So see this one. So if we target the middle 1/3 of the posterior knee and we put our probe in a longitudinal axis, then what are the structures we will see from posterior to anterior? At least what structures should there be? We will not see all the structures. Then we know that ligaments, I am talking about the ligaments. Okay, in the middle portion there is, of course, muscles are not there. Muscles are by the in both the sides. So which ligaments we will see? So we will see the meniscofemoral ligament. First, here will be the posterior posterior meniscofemoral ligament. Then we will see the PCL. Then below that there will be anterior meniscofemoral ligament, and then it is the anterior cruciate ligament, ACL. So of course we will not see all the structures, but at least we will see the posterior meniscofemoral ligament, and then below that, that is the PCL. So for demonstration purpose, as I told you that patient will be first in the prone position, and we will see these structures one after another, and then we will be seeing the we'll go for the lateral view, lateral demonstration. So then we will see these structures one after another. So so let us come to the pathology and clinical application of this musculoskeletal ultrasound, posterior side ultrasound or lateral side ultrasound of knee. So here patient can come to you with a lateral knee pain. So lateral collateral ligament sprain is one of the reason, and then lateral meniscal tear also can be the cause, and then iliotibial band tendonitis, iliotibial band tendinopathy. This is also a very important cause for lateral knee pain. Here only the lateral superficial lateral knee pain I am talking about. And then posterior knee pain, you can see most of the time it is popliteal cyst or Baker cyst, or even the PCL injury, posterior cruciate ligament injury. Fibula syndrome. Fibula syndrome is also, fibula is a sesamoid bone inside the tendon of the lateral gastrocnemius head. So that also can cause inflammation, and it can swell up, and there can be a pain, fibula syndrome. So and otherwise tendinopathies, different type of tendinopathy can cause posterior knee pain, like biceps femoris tendinopathy, semimembranosus, semitendinous tendinopathy, gastrocnemius tendinopathy, even popliteus tendinopathy. So all these has been reported till date. Okay, some causes I have written here that can cause pain not only in the posterior side or lateral side, any side actually. So arthritis can cause pain, global knee pain, or ligament injury. It can cause ligament of any side can get affected, and it can cause pain. Mostly the ligaments, very small ligaments, which I have not shown. I mean I cannot show the small ligaments of the posterior corner of the knee or the medial corner of the knee, very small ligaments which are seen by MRI. So they also can get injured, and they can cause a chronic pain. So for diagnosis purpose, at least if ultrasound doesn't show, then also you can send the patient to MRI and go for the diagnosis. And then entrapment neuropathies, as I told, post-op neuroma. After TKR also many patients get this type of superficial nerve, cutaneous nerve neuropathies, and pain, a different type of pain can go on. So these patients can come to us. So as far as procedure videos are concerned, so Baker cyst aspiration video and biceps femoris tendinopathy video, it has been uploaded as a you can see from your app. It is there in the free material videos. Okay, so you see from there. Others actually I'm not. I will search actually where is there. We have done a few cases of common peroneal nerve hydrodissection also, and lateral collateral ligament PRP injection also, that I will search. But these two videos you will find in your app free material section. Okay, thank you. Now we will start the demonstration.